Thank you, Shanna. My name is Amanda Brown. I'm Senior Vice President of Growth. It's a pleasure to meet everyone today. I've been partnering and working with our team here for the past 5 years, but serving across healthcare for all my career. But we are looking forward to this follow-up meeting with some new faces and some familiar ones. And I'll turn it back over to Michael to continue on. Thank you.
Thanks, Amanda. And yeah, for those I haven't met, I'm Michael Handley. I've been in healthcare for 15 years or so, all different, I guess, parts of healthcare. But yeah, I'm responsible at TransferAll for helping grow and expand our existing networks and markets, and obviously working to bring what we do and solve some of these challenges in new states we're working with. So definitely appreciate the time today. Everyone should be seeing the screen here. So for those that were on the session, I think last Tuesday, this will probably be repetitive, but bear with us here. And I know there's some recordings and things being shared after the fact, but we'll kind of keep the same flow that we had last week. We just did introductions. All for those that weren't on the first call or aren't familiar with transfer, I'll go through some slides and share a bit more about how we got to where we are, a lot of the big problems we're solving as it pertains to behavioral health, and then share a little bit more about some real world outcomes, and Shanna can to share a little bit her experiences with some of these organizations, and then definitely spend the bulk of the time walking you through the system, how it works, how it's digitally connecting providers to make things more efficient and ultimately get those patients placed faster. And then we can wrap up with, walking through implementation, onboarding, any questions the team has, things like that. So hopefully that still works for everybody. But obviously, if there's questions that pop up along the way, feel free to stop us. And I'm sure at the end, y'all will have some time together to discuss further. So really the big thing TransferAll is doing, not only is it a behavioral health specific, platform designed to improve the whole patient transfer care coordination process, but it's really driven around and created around the concept of eliminating all those necessary delays that happen when you go through the process of, a patient presents with mental health crisis, trying to find bed availability, communicate and find these facilities. So by eliminating some of those delays that happen with calling around, faxing, texting, emailing, TransferAll is eliminating those and digitally connecting providers throughout different communities and states through a real-time secure platform to quicken response times, acceptance times, but also help those teams that are searching for availability to clinically match those patients and speed the process up of getting those patients out of the ED and into the right level of care. So you all know this, right? And this is a big reason why Shannon, the founding team, created this, right? These patients are sitting in the ED, very prolonged waits, right? They're typically 1 in 8 ED visits, and then as you know, right, they're sitting there 3, 4, 5. I mean, however much longer than a typical medical patient. So, the fact that they're sitting there in emergency departments, right, is impacting a lot of different things. Not only the patient itself from a safety and harm perspective, but you've got EDs that are getting overcrowded with psychiatric patients laying in stretchers and hallways. So, that's delaying care for other patients. And of course, financial implications that happen when you think about patients that sit there, days and weeks, sitter costs, boarding costs, things like that. And then ultimately, right, when you're thinking about inefficient processes or just what the staff is doing on a day-to-day basis, right? They can get very burnt out and stressed with just the different hoops and hurdles they have to go through just to find availability for a lot of those patients. Which, as Shannon mentioned, led to them kind of creating and coming together as an organization, as a founding team, witnessing this firsthand in the hospitals they worked in. So, really wanted to create a better way to do it, to again alleviate those elongated wait times, but also to make staff life easier and make things more efficient. So created a real-time tool that, like I said, is helping to connect different healthcare facilities across communities to improve and drastically speed up the the care coordination process for those behavioral health patients. So a lot of what you'll see today is really, and I'll focus on this a lot around digital workflows, but also providing this instant connectivity, right? We've heard a lot of challenges through the state of just, lack of or challenges with inconsistencies with the transfer processes. And then two, just the finding better ways to communicate and collaborate as organizations across the state and community. So, how can we get patients into the right level of care, but can we get them closer than we might be seeing them now, right? We've heard there's patients going 4 or 5 hours away when they could be placed maybe 10, 15, 20 minutes away. So how the system can help match those patients to those facilities, and then two, just modernizing things and replacing the lengthy processes of those phone calls, faxing, and emailing that happens today. And of course, doing that on a very secure, HIPAA compliant, PHI protected system to allow for that secure messaging and real time document sharing. We're working with, health systems, hospitals, community mental health agencies, crisis teams. So really anyone that's kind of a part of that behavioral health care continuum we're working with today. And these are some of those names that have kind of trusted to partner with us to really solve those problems and kind of be viewed as some of those innovative leaders in those states that they're operating in today. I'm going to go into a few outcomes here before we get into the demo, just to give you some understanding of kind of what we're looking at and some real world examples of folks that have seen just quickly after implementing TransferAll. But there's two things we're looking at. One of those challenges we talked about, right, is understanding who's got capacity, getting responses back from those hospitals that you're working with. So we're looking at two different things, initial response time, or, when those facilities are responding back to our request, to give some sort of acknowledgments, not only that they received the request, but also do they have capacity to take that patient. So with the digital workflows and communications that are happening in the platform, those systems that are sending out those referral requests, they're getting responses and real-time availability from those facilities in about less than 2 minutes. Now, the response times a lot of times are faster, which you'll see, but as far as someone responding back and saying, "Hey, we've got capacity, we can take your patient," that's typically happening in about 2 minutes or less. And then when you think about the ability to actually get that patient clinically accepted into the right level of care, typically we see it about 8 hours or more with those processes of faxing, emailing, some of the more manual workflows. With TransferAll, and this is looking at across our entire network across the country, the average time for patients to be clinically accepted that are being transferred through our TransferAll network is now down to 34 minutes or less. So comparing that to the national average, what we're seeing through the digital network across the country, you can see how those times are drastically improving with getting those patients placed into the right level of care. And all that's happening with the ability to send out digital referrals, but also get back those real-time responses and notifications from those receiving entities. So real quickly if that patient can get into that facility or not. Just a couple examples here from an outbound perspective. So again, we're currently live in 16 states. I believe patients are getting transferred across 30 or more through our network. But as far as having extensive customers of sending and receiving facilities, we're currently live in 16 states, and obviously we're actively working with and outreaching and building out networks in some new states as well, obviously South Carolina being one of those. So the network and markets we work in and are actively engaged in are definitely seeing a lot of growth here the last couple of years, and continue to see that through this year and the future years as well. There's a couple examples I thought would be worth sharing because they're looking at kind of two different levels. One being how a crisis team kind of partnered with um, health systems or hospital team to improve care coordination, and then how a large health system out in California had kind of redefined and really transformed their processes to improve access to care for behavioral health patients. So I'm gonna Shannon, you can add some color here, but really what happened here was Merced County out in California, right? They partnered with Dignity Health teleassessment team back in 2023 to really help just improve the work they were doing for those behavioral health transfers. They were seeing about 24 hours or more, very excruciatingly long boarding times for their patients. So those transfer times were taking about 24 hours or more to get those patients out of the ED and into the right level of care. So they eventually adopted TransferAll to, of course, streamline that process and book productivity. And then ultimately, right, they eventually, after they implemented TransferAll, going from 24-hour placement times to about 30 minutes or less, after implementing a digital workflow like TransferAll was certainly a significant time savings, and improvement to their process overall. Shannon, I thought it might be good for you to just add some color there. I know you're very close to the work we're doing in California, so.
Absolutely. Yeah, this is a great opportunity for these hospitals, especially since they had a workflow that included both their own staff in the emergency room trying to place patients, but they had to collaborate with an outside county crisis team. And so the way that the platform works is it's not only able to link a sending, referring organization with a receiving organization, but if there's a command center or there's an outside placement team, it can link all three of these entities together to help make sure there's real-time status updates, communication, again, reducing the back and forth phone calls, not only between a sender and a receiver, but between a sender, a receiver, and a command center or a crisis team. So they saw excellent results. And I had the opportunity to speak to both the hospital teams and also the county. The county had significant improvements, not just in reducing the time that it takes for patients sitting in the emergency department, but on their own staff's time that they were using. So highly trained clinicians were looking at some significant improvements here in staff productivity. And the way that they're able to use their resources as well. So lots of improvements in drastic times in terms of reducing the amount of time to find that placement, which ultimately ends up reducing that total ED door-to-door time, better experiences for those patients. I mean, I think it brings this cost savings down to the hospital level as well, which I'll talk a little bit more when we talk about Sutter Health here.
Yep. Yeah, thank you, Shannon. Yeah, Sutter Health was the other one here out in California. So this was an interesting one, a very big health system, but they were doing across 21 different emergency departments, they were doing things 21 different ways. So you can kind of imagine the challenges there, right? They didn't have a really unified way of transferring behavioral health patients. So obviously wanted to come up with some sort of unified and collaborative approach to do that across all their different facilities that they were working with today. So Shannon, I know you've been very close to this, so
Yeah.
I'll let you kind of talk through this slide and some of the other results that may not be shared here on this one.
I think when I look at the results here from Sutter, there's a couple of things. You streamline and take away a lot of the friction that happens on the referral side. So they have a command center, streamline their approach using a technology. You can see shift after shift exactly what's happened, what hospitals have been tried, what their responses are. And you're moving from phone calls, you're moving from faxes, or different types of ways of sending referrals. Maybe it's through an electronic medical record, or it's through fax, or you're calling. These receiving hospitals, when we have that approach, they have a hard time organizing all of their work and streamlining their work. So one of the things that TransferAll does is it has an intake tool that helps them streamline all of their inbound requests and give responses and work as a team. So when we look at the results that Sutter Health gets, it's because also the receiving network also streamlined their approach. And so it's bringing together this entire network on a system that's digital. And so what we saw by doing this in the central Northern California area with Sutter Health and the entire network of receiving hospitals, so that could be crisis stabilization, empath units, inpatient units, residential, substance use disorder, right? Any patient that needs to be placed out of their ED, they can now do that through TransferAll. And they saw system-wide a 30% ED door-to-door time. So while we track a lot of data in TransferAll to say how much time can we reduce to find an accepting hospital, which has been significant and keeps getting faster. what we always want to go back and verify is this reducing ED door-to-door time. And at Sutter Health, we were able to show, yes, on average, 6.5 hours per patient over the course of the first year of this launch. So that results in, that's just talking about cost savings when we're looking at how long these patients spend in the emergency department, better quality of care. But when we look at the cost savings in terms of staff productivity, how many staff do they need to be using, clinicians, in order to complete this function for their teams, it's significantly less as well. So it's been incredible to see what the receiving and sending hospitals can do when they streamline through this type of technology that takes a lot of the back and forth friction out of the process.
Awesome. Thank you, Shanna. And yeah, there's a great little clip I can send to as a follow-up as well that talks more about Sutter and has them with Shanna as well at an event, just sharing more about what they prior and obviously what they saw with the outcomes with TransFerAll. So I'll be sure to share that as well as a follow-up. So great. We'll get back to the slides here as we get towards the tail end, as we talk through some other onboarding implementation topics. But let's shift gears here. We can get into the actual system and kind of talk through the workflows and how the platform operates. So you should be seeing two different kind of windows up on the screen here, and I'm going to kind of depict this both ways. As Shannon mentioned, right, there's two sides to this. The left side of this screen, so this would be where those folks that are, whether it's a command center, right, the emergency department, crisis team, who have you, they would be using this part of TransFerAll to start the process of putting in the patient information to start that transfer request digitally through TransFerAll. And then on the right side of the screen here, this is that intake side of the platform. So this is what those psychiatric facilities, obviously other command centers, right, inpatient units are using to not only have a simplified, organized way to manage those referrals, but now they can use the system to one, manage all these digital referrals that are coming from folks using TransFerAll, and ultimately use it to digitally connect, communicate back and forth, and provide real-time acceptances, declines for those transfer requests. But this is also too viewed as a full intake platform. So, there's a lot of hospitals that, right, they still see fax referrals, email referrals, phone call referrals. So on top of managing it through digital referrals and communicating, other, facilities are also able to stream in faxes or emailed referrals they get. So everything's staying in one centralized location, a lot easier to manage, and make decisions on those referrals that are coming in. So let me start by just demonstrating how you start the referral process, and then we'll get into a lot of the different workflows and exchanges that happen with the system today. So as I'm going through this, and I know Melanie and last call, right, there was some questions about like integration. So we do have integrations with like Epic, for example, and I would just say those are certainly conversations we're happy to have with those that would be interested in going down the right route of integration discussions. But a lot of times, right, folks with Epic, they can use Epic to launch TransFerAll, and there's other things we could do with that integration. So I know that was a topic of questions, so I just mentioned that so everyone's aware that we do have integrations, and certainly something we could discuss. So again, as you're doing this, right, you're just putting in patient information. There are some required fields here, but essentially the information you're putting in here, what's happening is the system is going to clinically match based off this patient's needs demographics, and it's providing, on the next screen I show you, a list of clinically matched hospitals or inpatient units based off a distance away. And one of the advantages here too, from this being a sender-driven platform, is with our behavioral health focus, and where we're also different a little bit is we, like Shannon mentioned, we provide that network from day one. So we're automatically linking in all the different behavioral health hospitals and inpatient units into the network. So from day one, they're going to get a digital referral from a TransFerAll sender. There's just a couple different ways I'll demonstrate to the audience here of how those requests can be picked up. But from a sending side, right, it's sender driven, you're in control, and then we're linking everyone in order for them to get those digital requests. And then, like I said, there's different ways they're going to be able to view those and communicate back to whoever sent that request out. So we'll go through this here, right? Name, date of birth, their gender, this assessment team. So this is where Shannon mentioned, right? If there's a crisis team or, mobile assessment team, what have you involved, right? TransferAll does have that ability to link in third parties or other external teams to, be involved in that process, have oversights, or ultimately, right, if there are assessment teams that go out to assess the patient, need to place them, they can be assigned to this case, assess the patient, and then ultimately be able to find a facility that geolocates based off where the patient's actually being assessed at and located. You can choose the unit, COVID-19 status. A lot of folks still require that. You'll have a full list of different diagnosis, DSM-5 codes the patient might present with that you can choose from. And then as you just keep going down the list here, right, there's different things you can select. Radius is really where you want to start your search. So how far out you want to extend your search to find available units. That can always be changed as you go. Treatment, their level of care, high level insurance information. And then if you need to check these boxes, if the patient high risk, involuntary, veteran, right? Are they any sort of specialty programs they need to be part of to make it easier to narrow that search down? And then modality isolation. If there's any notes for the patient, you can type those into here so that receiving facility can see that information when it comes over. So usually this is probably like 10 seconds or so to fill in, but once you input this in, you're selecting facilities and now it's kind of starting that process. So here's that transfer card that is generating all the information I input on the previous screen, but also here's your ticker. So now the clock's starting. This is where we're obviously using and providing analytics and data to track placement times, acceptance times, things like that. So this also just helps keeps the staff on track with working through the process as quickly as possible. And then as you see at the bottom, now here's a full list of all the clinically matched facilities based off a distance away that the team can now start to choose from in order to get that patient placed. Before I do that, I want to talk about one other advantage here, which is the ability of sharing documents in real time. So, right, you're faxing 60, 70, 80 pages, right? That could take 30 minutes, an hour or more to come through. So the ability to share these documents in real time at any moment is also drastically speeding up that process as well. So again, instead of faxing this, emailing this, you can digitally upload these into TransferAll. So once you have that assessment, lab, packet, what have you uploaded, now, when you go to send these requests out, whether you sent out one request, 10, 15, that document's going to go over in real time so that facility can view that information and make quicker decisions. So we've got the document uploaded. Now I'm going to go down here and start the process of finding facilities of where I want to try to get this patient placed. For those hospitals, right, that they've got command centers or a lot of times we hear they try to keep as many patients within their network or system that they can. A lot of folks are, those larger networks or systems are using this from both aspects, right? They're referring out. They may try to get the patient to their inpatient unit first. In a lot of those cases, right, we're able to prioritize those and put them at the top of the list. That's kind of their first pass to keep that patient inside their system. And then if they need to refer that patient externally, then of course they can continue to search for those facilities through the left side of the screen as well. So we see it done both ways, right? Health systems are using it to refer to themselves and obviously manage their incoming referrals, but also to send it out externally to standalone hospitals or
And Michael,
other available
could
units. Go
could
ahead.
I jump in? I think this is a good moment to mention that on the receiving hospital end, that this is not a closed system. So the receiving hospitals, you can create your radius of how long you want people have to drive or to get there. But the transfers, when you request a transfer and you say no radius, it could pull up hospitals across the country. It's not a closed system. So we're talking about referrals to potentially hospitals outside of the state.
Yeah, that's right. That's a good point, Melanie. Yeah, thank you. And yeah, you can always extend your radius or don't put a radius, but yeah, there's folks that are transferring patients within their own state. And then, like you said, Melanie, if they do need to go out of state or cross state lines, then yeah, definitely can be used to send patients wherever they need to go if for some reason they do need to go out of state as well. So
Then
the
the other
radius definitely
item,
does help.
Michael, is that you see up at the top too, you can search by zip code. So that's
Yep.
helpful too, because sometimes patients will show up in your emergency department or they're from far away. Maybe they've traveled and you want to find resources close to where they live. So there's flexibility there over state lines or searching. Or maybe the patient's home is 45 minutes. And you don't know exactly which hospitals are closest there. So you just pop the zip code in there. It'll resort that list in order of geographic distance as well.
Yep, good point. Jana, thank you. Yeah, then obviously there's other filters, right? You could exclude out of state or preferred facility. You can flag facilities and star them to make them preferred if they're ones you typically refer to a lot, right? Or they might be your inpatient units you're trying to get to first. So definitely can prioritize facilities that way as well. So, okay, we've got the document attached. Now let's start going through the process of selecting where we want to get this patient placed to. So, like I said, you can check every hospital you want, or you can be a little more targeted, right? Maybe there's patient preferences, or these facilities are typically take that type of patient you're sending to today. So, let me show you both examples. So again, as I mentioned, right, there's two different ways folks can get these requests and respond back. And we help by giving you sort of identifiers to know how they're involved with the network. The first example I'll show you is that portal, and this is that example of us linking in say a hospital that may not be using the intake side of our platform, but they're still going to get a digital request from that referral source. The only difference is those portal users, they'll get that, they'll get a unique access code, and then it typically is received through like a fax or an email with that access code that they'll then be able to go into, view that request, any relevant attachments. And the only difference here is they would just call back the specific information that was provided from that referral source. Where we've notated them as transfer all intake, that tells you they've maybe moved off the portal, went to the intake platform. Now they're not only using it to manage every referral, digital fax, phone call, walk-in, but now they're going to be able to view all these digital requests that come in. And more importantly, this is where those quick response times comes into play. Now they can get real-time alerts, notifications, message and communicate back to the referral source, and then also be able to provide within one click a real-time accept or decline on those patient requests to again avoid the back and forth phone calls, getting put on hold, just speeding up the process and communication altogether. So I've got these three facilities selected. I'm going to send a request and you'll see it'll give you a confirmation. And then for those portal users that are linked in, you're just going to give them specific name and phone number so they know exactly who to call back, who to ask for when they get that request. So we'll send the request. You'll see an alert pop up here on the right. From a user perspective and anyone wanting oversight, this is really valuable here because now you've got an outbound queue of these three requests you've sent out. And they're also all providing real-time statuses and read receipts, right? We always hear folks fax, they call, did you get our fax, right? Or they get put on hold. So now when these requests are getting picked up or looked at, the referral source is getting a real-time read receipt so they know, okay, they've got the request, they're probably looking at it, and we should expect some sort of response back soon. So, and I'll explain this a little bit more as we go through this, but before I get into the intake side, let me just quickly talk through the portal. So they got that portal request. It looks something a little bit like this. So it's kind of, this is an email example. So you can see it's got just generic PHI protected patient information. And then here's that unique access code and link. So generally, right, folks are copying the access code, clicking into that link. And then as they put in their information, now they're going to be able to view the request. So here's where it came from. Here's who to call back. Here's all the details of that patient. And now they can view that full assessment. How is this faster than faxing? Well, now I've got all 10 pages of these that I've just looked at in a couple seconds, right? We're still not waiting for all those faxes to come through. And typically, a lot of times, what's happening, right, when they get this portal request, they're looking at it, they're calling back pretty quickly, either requesting more information or letting them know, hey, great, we can take your patient. They might start the process of discharge and admission. So, this was an example of, again, we're linking in those behavioral health hospitals or units. They're getting digital requests. They're just not participating on the intake side. So they're just going to pick up the phone and call you back with next steps for that specific request. Any questions on how that piece works before I get into the meat of the intake platform and the communication side of it? It's okay if not, just want to make sure. Okay, perfect. So let me shift gears again. That was an example of we're linking a facility in, they're getting a digital request and they're calling back. Now, where a lot of these, this is really a lot of the value and benefit here with the platform from the communication aspect and how are we helping drive collaboration communication. So a lot of times on the intake side, right, the right side of the screen, usually they have this intake queue pulled up on a big screen or and really what's happening as these digital requests are coming through, they're looking at this, monitoring this, and so now they're able to quickly see them and pick them as they come across. So here's the one we sent, right, to XFERALL Behavioral. You can see it was red. So you're clicking into it. Now on this side, right, I can see it came through. I'm on an inpatient unit or standalone hospital. Here's that request. And now I can start to review all the information and kind of determine what I can do here with this patient. Number one, here's that attachment. So I can come in here in a couple seconds, view that all 10 pages of those assessments. I have what I need, right? And then you can start to take the next step. So I'll show you a couple of examples. One of them might be just as simple as like they're at capacity, maybe they don't have any beds, right? Instead of them calling back or texting you, what have you, this is where they can use XFERALL to click a button and communicate back. So in this case, right, XFERALL Behavioral's got no beds. They're hitting decline. If there's a declining provider, there's always going to be a reason that they have to choose for why they're declining the patient. So in this case, right, they may put rack capacity and they may say, try back in 30 minutes or an hour, right, to see if they've got availability. Now, what actually happens here, right? They declined it. Now that referral source got that immediate alert and notification and message for why it was declined. So that patient's declined. They can now go back um, and they can start to, if for some reason, right, they needed to get this patient out, they couldn't wait 30 minutes or an hour. You can always go back to the all facilities tab and then start to select other facilities that aren't grayed out. So you can continue to try to work through the list and trying to get that patient placed if you're finding all your previous requests were getting declined. In this case, though, maybe that time went by or something changed and they actually had availability open up. You may not even have to reach out to them, right? They could just use XFERALL to alert the referral source that they've got availability and have interest with taking the patient. And they could simply just click interested, and that would notify that referral source that, okay, great, something changed. They now got interest in taking our patient. Let's go ahead and select them as the facility where we want that patient to go. So the referral source selected XFERALL Behavioral. They got that immediate alert here that says they were selected. And now they can start to do a couple things, right? So you kind of see how the two-way communication's happening. I'm clicking buttons, messaging and alerts are going back and forth. So folks are always looped into what's happening. But ultimately, once that hospital's been selected, they can do different things. Of course, they can come in, view that assessment, right? They may also message back and say, can you please send labs, right? So now we're sending a message to the referral source to send labs. They're not faxing that over or sending it differently. They're using XFERALL to do all this. So now they can come in here, find their labs, and then they're going to be able to share this document to that hospital in real time. So once it's uploaded, there's that alert. Now in just a couple seconds, they're clicking into that to view the lab. Everything might look great. Let's go ahead and accept the patient. Is there administrator on call, accepting provider? Let's accept them. And then you can see alerts are popping up here from the referral side. They've been accepted. And then, right, discharge processes can happen, right? You may need to arrange like doc to doc or nurse to nurse calls. So you can start to arrange those and communicate through the platform when that's happening. But ultimately, right, once those steps are done, the patient's ready for discharge, arranging transportation. That's usually when a lot of these referral sources are clicking sent. They may notify just to say, ETA for arrival is 60 minutes to give that hospital a heads up. And then the last couple steps in the process, right? The receiving side would close the case out, and then it being a center-driven platform, the final step from the referral side is to click close. And now that case is closed, and that patient ultimately has now been placed and accepted by this facility in about 7 minutes, just by using a digital workflow, connecting providers, and being able to communicate digitally through the platform. What also happens too, and then I'll pause from an efficiency standpoint, is not only does this speed up the process of sharing documents, getting the patient accepted, from a staff perspective, now what's happening is you're not having to go back and notate or mark anything in the system. It's notating everything for you. So we had 3 transfer requests we sent at once. Once that patient at XFERALL Behavioral got accepted and placed, these other 2 were immediately closed out and canceled in the system because that patient was transferred somewhere else. So from a staff perspective, much more efficient. You're not having to go back and notate what happened to that previous referral. Once the patient's placed, those are all getting canceled out with the specific reason that they were transferred elsewhere. Let me pause and just see if there's any questions on kind of that workflow, the back and forth, how it's connecting and speeding up the process of communication and placements for those patients. Okay. So there's a couple other things that I thought would be worth talking to. I know we talked about a little bit last week, but there's other things that are happening too on the intake side that is helping those teams with obviously the ability to receive everything in one platform and speed up their response times and acceptances for those patients. But we also hear the challenges of those long assessments and documents that are coming through, staff having to kind of manually read through those and make quick clinical decisions. So we do have an AI component in XFERALL that's really helping with clinical documentation, reading those documents, and spitting out sort of summaries for the staff so they can make better informed decisions on that type of patient if it's something they want to take, accept or not. So what's happening, right, is when those referrals are coming through, right, whether they're digital or fax, that's really valuable on faxes, right? Because as those are getting faxed through, number one, folks can pick up all those different pages and look at them in real time so they can get back to them much quicker. But also AI is coming into play. So when these faxes are getting streamed in, it's providing this pretty detailed summary of the crucial information that AI picked up on the document. And then this is what's really helping those staff members read through those documents, decipher it, and ultimately, make quicker clinical decisions on accepting those patients. So, right, instead of them getting those faxes, waiting for 70 pages to come through, reading through it as much as they can, they're now streaming and getting everything in XFERALL. AI is picking it up, providing a summary, and then they can start to go through the process of kind of digitally creating that transfer. AI is taking it to another level of giving sort of these confidence scores of the information that's getting spit out in the document. So this is where the staff is still involved, right? They're still making these human decisions on these patients, but the AI is just speeding the process up and helping them do things a lot more accurately and quickly through that. So you can see the level of confidence scoring here. If you ever see something red or yellow, right, you can always click into those. It'll give you a very detailed reason for why it was flagged that certain way. And then if for some reason it needs to be changed or you found something that might have been wrong or in the document, right, those can always be clicked on to change the actual status or reasoning for that specific flag that AI caught. But ultimately, right, you've got that AI's picked it up, summarized the document, help you decide quickly if you want to accept it, and then ultimately, right, staff can create the transfer. It'll house all the documents and transfer, and then of course they can notate what happened to the patient, whether it was ultimately accepted or declined by that staff member who was reviewing that information from the patient. So not only is it just digitally connecting and speeding up the whole transfer process, but a lot of the AI stuff that's happening on the intake side is, of course, helping those teams work more efficiently. But that's also what's driving a lot of those speed and accuracy when you're getting those responses back and acceptances or declines from those patients, because that AI is coming into play and helping decipher and read those very long page documents that are getting transmitted over.
I think there's a
Go ahead.
question.
Yeah, go ahead.
Yeah, I had a quick question, Michael. I stepped away, but I just got back. I think I heard how the referring hospital gets notified that the referral's been canceled or the patient's been accepted. How does the hospital that's reviewing the patient to be for acceptance, how do they get notified that the patient's no longer needing a referral, that's been accepted elsewhere?
Yeah, it'll kind of be a similar way. They'll be able to see that the patient was like it was canceled and because the patient went elsewhere or was transferred elsewhere. So they'll be able to see it from both sides, what actually happened to those
And
requests and where those patients went.
And that
Yeah,
comes
and
through.
they'll come right off that inbound queue too. So if you're on intake and you're trying to create efficiency with all these inbound referrals, if the patient gets placed or discharged or they go somewhere else, you get a notification in the intake team, and then it just comes off the list because the patient no longer needs to be placed. So you don't spend your time working on cases that have been placed elsewhere.
Yeah.
Or that went home.
Thank you.
Yeah, good question. And yeah, there's a lot of that. That was kind of where I was going next, with just some of the data and insights that the system's providing to help with oversight, performance, times, and whatnot. So, I'll kind of show these from both sides, but from like a sending side, right? There's these different insights that you'll have from an outbound snapshot. So, you can always filter certain months, but this is all real-time visible data. Again, these are things we hear that either EHR doesn't provide, or a lot of times folks are just manually logging these. So like weekly transfer counts, you'll be able to have visibility into that. Our patients getting placed, how many requests did we send, right? Different things that are happening in the market. So comparing yourself with others in the state of as far as response times, interest times, acceptance times. So how those compare, what those look like from a daily perspective as well, to just see if it's staff resources, certain times of the day we're seeing slowdowns or increases. And then of course, everyone wants to know where patients are going, what's happening to our patients when they go there. So receiver mix just breaks it down to show you where patients are getting sent to, are they getting accepted or declined, right? And then of course, too, referral sources always want to know like who's responding, who's accepting patients, how quickly are they getting back to us. So we even let the referral sources know how quickly these facilities they're working with are responding back to their requests. And are they, accepting, declining them to help them from that perspective of, hey, maybe we should send patients here more or less for whatever reason. So a lot of times, right, we hear, those facilities that typically are responding first and quickest with those requests, they're typically the ones always getting those patients. So, it's always good to see how quickly those facilities are responding. And then for those folks that are still linked in, right, they're getting the portal request, you'll still have visibility into that, just to see the portals they got. Are they opening them, right? When they open them, are they accepting our patients? So you'll have visibility into all those referrals that are going out as well from the referral side. And then the intake side is very a lot of data. This is a lot of folks get a lot of value out of this. Matt, to your question, right? This is where too you can come in here and start to really see, again, what's our weekly transfer count looking like? Number one, you have a scoreboard. So this just kind of looks at each month. So you can see if you're doing better next month or the previous month as opposed to the next month, right? Again, where are you ranking with other hospitals in the state? Are those times improving? And then again, similar to what we just looked at, again, this is on the intake side. So those receiving facilities, they can see requests they received. Do they accept those patients? What the current different transfer statuses are looking like, and then we give those daily and monthly comparisons to the response and acceptance times. And again, right, those responses are those initial acknowledgments, either interested or communicated back. And then acceptance is, of course, they actually accepted the patient. So what those look like compared to others in the state. And then, of course, right, who's sending us patients, where are they coming from? But then you also can get visibility into it from a business development side of it, market side of it. You can really see how many requests these hospitals are actually sending, but also are they going to you or not? So like transferal also, you can kind of see the total number of requests they've sent, but also how many requests you specifically got. So it just helps kind of understand, are they sending all their patients to us? Why are we not getting a lot of their requests for whatever reason? So a lot of visibility into where patients are coming from, as well as payers came up a little bit last week. So we obviously show you too, just payer mix of the types of different payers and patients you're accepting month over month as well. And again, this is just an inbound snapshot. There's a whole nother layer you can keep getting into as far as team insights. So a lot of folks are using this to just hold folks accountable, but not even so much on obviously helping folks work better and more efficiently and paying attention to how quickly they're responding. But this is a tool we use a lot on the CS side to celebrate successes and the great work the team does with these response times. So it just helps keep the staff accountable. And again, like I said, celebrates all the great work the team does to continue to work through these requests and cases as quick as possible to get these patients in the door. And then these last two are really valuable. Really, this one I'd say more so the decline insight. So, right, Matt, this is where some of that comes into play from your question. But you can obviously filter in different decline reasons that popped up just to see what those decline count look like month over month. Is that decline rate increasing, decreasing? But then as you get down to the bottom here, you can really start to drill into filtering out specific requests, but then have this kind of full report of all the requests that your staff declined, right? Where we at? Why are we declining patients when we had beds, but we said we're at capacity? It's also great to, we use the example of adding new service lines or, right, we had a customer that, they found out they were using this and they were declining all kinds of patients because of wound care issues. So that led them to start a wound care service so they could start accepting those patients. So there's ways to use this to not only have visibility and oversight into practice performance and staff performance, but also to use it to identify new referral sources, improve relationships with referral sources, and again, if there's opportunities to add new service offerings or things like that to your hospital. There's a lot of different ways folks are using this as well to open their eyes and provide insight into that. So a lot of real-time analytics and insights and data into the platform on top of just the ability to digitally connect and speed up that placement and acceptance process for those behavioral health patients.
Michael, can you
Yeah.
talk a little bit about like how other referring hospitals handle patients that are not picked up by other hospitals? Like, what is the usual time frame they allow them to sit in the system, and then what do they usually do after that?
So I've seen different things, Shanna. I don't know how long they sit in this. Like, do you mind diving into that?
Yeah, absolutely. So, I mean, the tool is available for them as long as they're trying to place the patient. So there's many times, and it's completely driven by the referral source. So when you look at a sort of pre-post comparison, if you have a difficult to place patient before, you have staff shift over shift, making phone calls, leaving notes, of where they tried and what happened. In TransferAll, shift over shift, all of this is documented, and they can keep expanding their radius to additional hospitals that may be a clinically matched facility for the patient. So if that patient gets put on this outbound board and a lot of the hospitals come back that they have declined, they can try additional hospitals. Maybe a hospital comes back and says, well, we'll consider the patient, but they need to be off IV antibiotics, or you need to do these other medical things and send us labs. They can stay on there for as long as that hospital needs to and keep sending and updating those clinical documentation in the notes until they get the patients placed. And they can keep trying additional hospitals. So it's not like there's a time limit for where it automatically comes off. It just creates a much more cohesive platform that allows them additional options that maybe these staff don't even know are available. And I think I had mentioned before, we saw this all the time in Dallas. The social workers just kept trying and trying all these Dallas hospitals, but they didn't have a unit that was taking medically complex patients. But there was a Medi-Psych unit down in Houston. So those patients before were just sitting in the hospital and they just kept calling and calling, and then they would just wait until they got better on the med surg unit. Whereas now they were able to discharge that patient, even though they had to go a little bit further, they were able to find a match. So that's some of the value and the benefit of the system. It just allows them that approach using a technology tool that's tracking all of this and helping them find the resources they need and keep track of that communication and what's needed. Does
I think
that
Debbie
help?
had a question.
It's
Sorry,
Oh, yeah.
Shannon.
Sorry.
Yes, that's helpful information for sure. I can see how that can be more efficient
Yeah.
and less likely to have notes get lost or whatever reason.
Yeah, it's yeah, because it's funny. I always hear folks are emailing. I hear a lot. It's like after a shift change, right? That's like, well, we email staff and we tell them what's, what we did last or what's happening with the open referrals and even like Tiger text, things like that. So yeah, like Shannon mentioned, that's really helpful too from that perspective of new staff comes in, they can just see right away what
Absolutely. And
happened.
it helped me manage my team too, because I had this team of, clinicians that were trying to place these patients, and I couldn't really see transparently like everywhere that they try and what was the response. I got some of that back, but and did they try additional places once they got these declines, right? Did they pick up the phone and keep trying additional hospitals? I couldn't tell when it was a phone and a fax-based system. It was very hard to track. And I couldn't go back and really do case reviews on my complex patients that took the longest, right? So a lot of times when we work with our hospitals now, I go into the history section with our CS team and we say, okay, if we've reduced the time to place 85% of your patients because you move to a new, faster system and those patients get placed faster. But there's always going to be complex psychiatric patients to place. But now there's a place where we can go and do really detailed case reviews. What happened? How quickly did we try other hospitals? What did those hospitals say? What's the data on our geographic area? What people are taking or not taking? And that can help sort of create solutions. Or a supervisor can get on the call and say, hey, let's have a case conference with some of our psych hospitals about this patient that's been waiting for too long to move the case forward. So I think there's just a lot of options. One of the frustrations I constantly had, it was just hard to really concisely get all of this information, understand what was happening on my 12 patients that may be sitting on stretchers in my ER. And then what those hospitals had said back, because a lot of times it was on the phone. Somebody from those hospitals called back and gave an answer, and it wasn't really documented anywhere what all of those decline reasons were.
Thank you. That is good. And Deb has a question. Deb?
Perfect.
Yep. So my question is, I can see the value here, but there's a piece missing for me, and the piece missing for me is where there are available beds. So if I know a hospital has available beds and they're not picking up my patient, for me, this is like half of the information needed, not all the information needed.
Mhm.
Is there
So yeah, I can talk to that a little bit. So when you send a request out, these hospitals are responding right away that they either have a bed available and they're interested in taking your case, or they're declining because they're at capacity. If they decline because they're at capacity, you go onto a wait list. So those receiving hospitals have visibility that you're still waiting for the patient. When they have a bed open, they can see that and they can change to now we have a bed. We don't have the reason why we don't have the hospitals list their beds is because it's not real time. So we have them answer in real time if they have capacity, or if they clinically review the patient and they say what the clinical reason is that they're unable to accept that patient. So you get that right away. When we look at bed capacity systems, they're just typically very delayed with those beds being put in. And also there's operational opportunities, right? So we see that maybe a case comes through and they say, well, we don't have female beds right now, but we can move some patients around to bring your patient in. And so they're doing that in real time as they're looking at where they can move patients and what they can do. But that we do see very quick responses. Our median response back from our hospitals is 15 seconds nationwide to either say we're at capacity, we don't have a bed right now, or we're taking a look at your packet to see if we can clinically accept.
Thanks for that. My real life experience is that capacity is a very general term that doesn't always mean the same thing to all of us. So that's why I was asking the question, because I've had the experience being on a mobile crisis team where I call with an unfunded patient and there's no capacity, and I call 10 minutes later with a funded patient and there's capacity.
Right. And I think that, we've seen, and I'll tell you that we've looked at all the data across all of the patient populations, because there are these complexities that happen in behavioral health, and we have seen all patients be placed faster. It does not resolve all of the challenges that we have in the behavioral health system and issues with certain types of patients being more difficult to place, and that goes from everything from, sometimes funding sources all the way up to, of course, the patients in the ED, we have EMTALA, but if they're not in an emergency room, we don't have EMTALA. And so, those regulations are different depending on the originating location of the patient. And then there's complexities clinically about what facilities can take or not. What the system does do is allow us to understand what types of patients we may need more services for, what hospitals can take those patients. But I will say one of the benefits when we look at every single category of patient is that we've been able to reduce how long it takes them to get placed. So it's not, and I hear you because I've been in the ED, I've had the same problem, right? But even if I list how many beds they have at 8 a.m., the challenge is it doesn't solve all of those challenges. So we're looking at this sort of real-time response rate as the opportunity here. But there's plenty of room always, even when we move to a system that makes it better for some things, it doesn't do everything that we want it to, for sure. I mean, there's always rooms to continue improving. Absolutely.
Great. Thanks, Shanna. Good questions. Okay, I know we've got about 20 or so minutes left. I do want to make sure we leave time for everyone to gather and ask questions or talk amongst the team. But Melanie, do we want to kind of go the same flow we did last week and kind of go into implementation, onboarding, and
Yes, if you would talk about implementation piece, and also I think it's also important for this group to know that your work around EMS and how that's a future, to be able to ping EMS for transport or other providers for transport. Will you mention that and then go into implementation and how that works?
Yeah, so
Sure.
Today we don't have a feature that pings EMS. EMS has used the platform to find placement. I think if there was a request for this in a certain region, it's a feature that we could consider if there's interest in it. But primarily what we have today is that the folks who have the patient they need to place, whether it's fire, EMS, school districts, police, any referral source can use XFERALL to help find placement today as is. But if there are feature requests, we always love to get those because we want to keep expanding how we can expedite that entire transfer process.
Okay.
Michael, did you have anything else that you wanted to talk through on that?
No, I think that was the big thing, just that EMS is doing it
Yeah.
currently. So yeah.
Okay. And just in terms of the implementation process, it is a very light technology for healthcare systems to implement. So when we think of some of the projects that are involved with technology, they can seem really overwhelming, but I will say this is very light. Typically, we're finished with the full implementation, and hospitals are up and using this to either send or receive patients in 6 to 8 weeks. We've had hospitals go up much faster than that as well. But it is a kickoff call with sort of the project lead. We do a technical setup. There's not a lot of technical lift, but things like if your system wants single sign-on, or we can set up an account administrator with multi-factor authentication, and you can add your own users and manage them. And then we'll do these training webinars for the team. So the staff actually doesn't have to have a lot of time with us. We also have learning guides and videos in the app, but they can attend one of these live webinars and then they can log into the system and practice. And then we set up a time period for testing. So if you're a receiving hospital, we'll start sending your team requests during the day, overnight, on weekends for a period of 1 to 2 weeks to make sure your response times are good. This has helped us really get our response rates to almost 100%. It's like 99.9% of all referrals that go out on this TransferAll network to a participating receiver getting a response, which is a significant improvement from what happens when I used to send out a fax, not knowing if somebody called me back or not. And so we get that testing window done, we get the response times, and the senders, referral sources can practice sending cases, and then we turn the system on. For the initial market go live, we make sure everything is linked up so that you can send all of your referral sources. We do use SAMHSA and CMS databases for all licensed facilities, but we do a double check to make sure that everybody is in there that you're sending to. And then after go live, we provide 24/7 support and ongoing account management. So we do engage in this process of using data to continue driving improvements over time as well.
And I almost want to tick on that because you did mention something that I think is important implementation wise, and that's so when you have a hospital sign on to be a referring hospital, you're basically going out and you're looking at all of the facilities that they refer to, and you're bringing them on to you're linking them to the transferring hospital. But all of those facilities do not have to be on TransferAll. If they're not on TransferAll, then they're getting an email. My understanding, right? You're getting an email that says click on this with this secure code to view this transfer request. But if the receiving hospital is on TransferAll, then that's when you get the full functionality that you've gone through. So there's that little minor difference. So it's only functional completely if the receiving and the referring hospital are both on TransferAll.
Correct, for the bidirectional communication piece, but even if the receiving hospital is not on the full version, they're still going to get a digital request. When they open it, the team at the referring hospital will get an alert. So they'll be notified in real time that somebody looked at it. They'll know who looked at it, what the direct callback number is. That'll all be documented in TransferAll. And then that referral source can document, did the patient get accepted? Are they reviewing the case? And then if the case gets declined, they can still categorically document why, so that you can have that big picture of in one place of what all of these acceptance or decline rates or the decline reasons are from all of the places that you're referring to. Yeah. All right. I think that's it, Michael, on the implementation process.
Yeah, great. Thanks, Shanna. Do we want to leave time for questions and answers? Well, I know pricing was at least something you wanted to hone on. So I can just share like we did last week. So our platform is just typical kind of subscription software as a service. So it's a subscription model based pricing. Typically, we're looking at there's a one-time implementation fee that applies, and then usually it's based off of number of licensed beds, either looking at like acute licensed beds on the referring side, and then of course from a psychiatric bed count as well. So just your typical monthly subscription fees based off of bed counts.
Okay. All right. If individual hospitals are interested in learning more about pricing, they can just reach out to you directly.
Yeah, absolutely. I'll definitely send out an email to everyone on this call or to the invite with everything. But yeah, they're definitely, if they have specific questions or want us to dive in on anything deeper, definitely can reach out to me. We're happy to do it.
Okay. All right. If are there any other questions? I might just let the transfer team drop off, so us hospitals could talk about it. But are there any other hospital questions to the transfer team? Okay, Michael, Shanna, Amanda, thank you all so much for talking with us today. I'm going to let you. He's put his email in the chat. I'll let you all drop off and follow up with an email following the call. Thank you
Thank
so
you
much
so
for your time
much.
again
Great.
It was
today.
great to
Thanks,
talk
y'all.
to
Have
you
a great day.
today.
Nice to meet everyone. Thank
Take
you.
care. Bye.
See ya.